just waiting for them to start. So we can go ahead and start with the session actually.
Okay, fine. Just drop in a message to me once they are ready, probably midway through or at the end, we'll do it. Fine?
No worries. Thank you so much. So, greetings everyone. It gives us immense pleasure to welcome you all to the ninth session of GynoScope, a collaborative academic initiative brought to you by Dr. Aditya Nimbkar and SIMSOG. It is a unique series which was envisioned with a singular goal to create a space where young medical minds can come together to learn and question in the field of obstetrics and gynecology. Today we have with us Shubhra Mittal and Tanaya Shah from Greetings everyone. It gives me immense pleasure to welcome you all to the ninth session of GynoScope, a collaborative academic initiative between Dr. Aditya Nimbkar and SIMSOG. It is a unique series which was envisioned with a singular goal to create a space where young medical minds can come together to learn, question, and grow in the field of obstetrics and gynecology. Today we have with us Shubhra Mittal and Tanaya Shah from Lokmanya Tilak Municipal Medical College and General Hospital Sion, presenting to us hyperglycemia in pregnancy. We're so grateful for the enthusiastic participation from colleges across the country and for the opportunity to build a stronger, more connected academic community. So thank you for joining us today, and we look forward to an engaging session ahead. Over to you, Dr. Namkar.
Hi, everyone. So, welcome back to the ninth session. Hyperglycemia in pregnancy, very significant. These are few of those patients who you would find chronically admitted in your wards because they'll be often on insulin titration to get the optimal dose. So, they are often going to come up as your exam cases for undergraduates as well as postgraduates. So, Tanaya, Shubhra, are we ready with the presentation? Tanaya, Shubhra. Tanaya, kindly unmute yourself.
Hello.
Yeah, Tanaya, you're audible.
Yeah. Okay.
Just share the presentation and you can begin.
Yes.
All the best. Just read out the case and then we'll go with the question answers.
Yes, sir. So the patient named Mrs. ABC is a 35-year-old resident of Dharavi, housewife by occupation, Muslim by religion, studied up till 5th standard, belonging to lower socioeconomic status, is married since 13 years in a consanguineous marriage, third degree consanguineous marriage, has a parity score of Gravida 4, parity 2, living 2, abortion 1, with previous 2 LSCS. Her last menstrual period is on 22nd of December 2024. However, she has history of irregular menstrual cycles. But when calculating expected date of delivery by Naegeli's formula, it is 29 September 2025. Expected date of delivery by scan is 15th of November 2025. Currently, her gestational age is 26 weeks and 5 days. Date of admission was on 13th of August 2025 and date of examination is on 14th of August 2025. So the patient came for follow-up where it was noticed that she had deranged sugar on OGTT test and therefore was admitted for evaluation and optimization of blood sugar level. There's no complaint of pain in abdomen. There's no complaint of PV leak or bleed. There's no complaint of decreased fetal count. Pre-pregnancy weight was 70 kg. Initial BMI was 34.7 kg per meter square, which is grade 1 obesity. Currently, her weight is 74 kgs and currently BMI was 36.7 kg per meter square. This pregnancy was spontaneous conception.
Hello.
It was... Hello, am I audible?
Yeah, you're absolutely audible. You can continue.
So pregnancy was confirmed on urine pregnancy test by a doctor when the patient approached for fever at Sion Hospital. It was undocumented and no diurnal variation was seen. Fever was not associated with rash, chills or rigors and used to get relieved on paracetamol. She also gave history of irregular menstrual cycles and period of amenorrhea since 4 to 5 months, for which UPT was done. This was followed by dating scan which suggested pregnancy since 2 months. She was advised admission for further evaluation of fever in pregnancy, but she denied. She was not compliant for performing any of the antenatal tests at that time due to family issue and was lost to follow-up. There were no antenatal visits thereafter in the first trimester. No history of excessive vomiting, bleeding PV, exposure to radiations or drug intake except paracetamol and Tylenol 150 microgram tablets. The patient did not take any folic acid supplements. Nuchal translucency and nasal bone scan or duo marker tests weren't done. The patient came for her second ANC visit at 17 weeks plus 4 days when she was advised to undergo routine ANC tests, and she also received first dose of TD vaccine. She registered her pregnancy at Sion Hospital at this visit. However, she got her tests done at 23 weeks and 3 days of gestation when her fasting blood sugars came out to be deranged, for which she was advised OGTT, and she got her OGTT test done at 26 weeks and 3 days. So the values of which were as follows. Fasting blood glucose was 103, 1 hour postprandial blood glucose was 198, and 2 hours postprandial blood glucose was 149 milligrams per deciliter. She also had deranged thyroid function tests suggesting hypothyroidism. Patient was thus admitted for further evaluation. Anomaly scan was done and was told to be normal. Quickening was felt in 5th month of gestation. Iron, folic acid and calcium supplements were taken. There is no history of polyphagia or polydipsia. No history of headache, blurring of vision, epigastric pain, decreased urine output. No history of burning, micturition, fever or vaginal discharge. Past history, she is a known case of hypothyroidism since 6 years, currently on Tylenol 150 microgram. She hasn't been taking the medications regularly and is non-compliant. She is also a known case of polycystic ovarian syndrome since 6 years, for which she took oral contraceptive pills for a month and then discontinued the therapy. There is no history of hypertension, TB contact, epilepsy, asthma, blood transfusion or surgical illness in the past. Her menarche was attained at 15 years of age. Initially, her menstrual cycles were regular. She had a 3 and 35-day cycles, soaked 2 pads per day. However, since last 6 years, her cycles have become irregular, once every 3 to 4 months. These are painless cycles lasting for 2 days and hardly soaking 1 pad per day. Past obstetric history, Gravida 1 Living 1 is a 11-year-old healthy female. Birth weight was 2.9 kg. It was a term delivery. It was an institutional delivery at KEM hospital. It was done by LSCS in view of fetal distress. Baby cried immediately after birth, breastfed exclusively for 6 months. No history of NICU stay, immunized completely. No history of any comorbidities during pregnancy. There was abortion G2A1. Missed abortion had occurred at 10 weeks of gestation, following which dilatation and curettage was done. History of hypothyroidism and polycystic ovarian syndrome was present. G3L2 is a 4-year-old healthy male. Birth weight is 3 kg. Term delivery, again institutional, by LSCS in view of previous LSCS. Baby cried immediately after birth. Breastfed exclusively for 6 months. No history of NICU stay. Partially immunized until 14 weeks because of fear from vaccines, for which we counseled her. History of hypothyroidism and PCOS during pregnancy, and no other comorbidities were present. So this was her dietary history. She consumes a total of 2,115 kilocalories and 69 grams of protein. There's no dietary deficiency noticed, but since this female was an obese woman, she was supposed to take 1,300 to 1,600 kilocalories per day. Hence, she is having increased calorie intake, while protein requirement is adequate. Diabetic diet is not followed. So this was just a comparison of her diet versus recommended diabetic diet. Family history is not significant. There's no history of hypertension, diabetes mellitus, epilepsy, thyroid disorders, TB, asthma in the family. Personal history, sleep was adequate. Bowel and bladder movements are adequate. Denies addictions. No history of use of contraceptives. Environment in house is supportive and healthy.
Continuing with general examination, the patient was examined in adequate light with her due consent. Build is obese, nourishment is adequate, height is 4 feet 8 inches, weight is 74 kgs, and BMI is 36.7 kgs per meter square. Acanthosis nigricans or hirsutism is not present. There is no abnormal gait or spinal deformities seen. Temperature is afebrile. Pulse is 85 beats per minute, regular. Respiratory rate is 22 times per minute, abdominothoracic. Blood pressure is 118 by 76 millimeters of mercury. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. On obstetrics abdominal examination, inspection, the abdomen is uniformly and craniocaudally distended. Umbilicus is flat, linea nigra and stria gravidarum is seen. A linear scar of classical caesarean section and another transverse scar of LSCS are visible on the lower abdomen, and there is no discharging sinuses seen. Cuff impulse is absent in the hernial orifices. Palpation, abdominal girth is 109 centimeters. Fundal height is approximately 28 weeks and symphysial fundal height is 26 centimeters. There is no scar site tenderness felt. Leopold's maneuver, first grip, broad, soft, irregular, non-ballotable mass suggestive of buttocks. Second grip, left side, left, hard, curved, broad-like structure suggestive of back. On the right side, small knob-like irregular parts felt, suggestive of limbs. Third grip, smooth, hard, globular, and freely ballotable structure felt, suggestive of head. Fourth grip, fingers are converging, therefore not engaged. However, Leopold's maneuver is less significant at this gestational age. Auscultation, fetal heart sounds heard on left spino-umbilical line, 155 beats per minute, regular. Systemic examination, CVS, S1 and S2 heard, no murmurs, RS, air entry is bilaterally equal and normal breath sounds heard. CNS, patient is conscious, cooperative, well-oriented to time, place, and person, and there are no focal neurological deficits seen. Thyroid examination, no palpable swelling seen. Breast examination, breasts are bilaterally symmetrical with normal skin and evoted nipples. No cracks, retraction, or discharge noted. On palpation, breasts are soft and non-tender with no lumps or lymphadenopathy. Summary, Mrs. ABC, 35-year-old, known case of hypothyroidism and PCOS with irregular menstrual cycles since 6 years, with parity score of Gravida 4, parity 2, living 2, abortion 1, with previous 2 LSCS presented to the OPD at 26 weeks and 5 days of gestation with deranged OGTT test and TFT values, and has no specific complaints. Fetal movements were perceived well, and there is no history of abdominal pain, PV bleed, or leak. She has been admitted currently for evaluation and optimization of blood sugar levels. She has 1 episode of fever in the first trimester for which she took paracetamol. She has been irregular on her ANC follow-up and is a poorly compliant patient. There is no history of GDM in previous pregnancy. The patient is obese and is consuming higher calories than recommended during pregnancy. On examination, blood pressure was 118 by 76 mm of Hg. Fundal height and symphysial fundal height are appropriate for gestation. There is a singleton live fetus in cephalic presentation with fetal heart rate of 155 beats per minute, regular and heard on the left spino-umbilical line. Provisional diagnosis, Mrs. ABC, 35-year-old, known case of hypothyroidism and PCOS since 6 years, with parity score of G4, T2, L2, A1 is probable case of early gestational diabetes mellitus under evaluation with singleton live fetus, not in labor. Thank you.
Great presentation, Tanaya and Shubhra, especially the dietary deficit part, the pie chart that you had made. Excellent, lovely. Could you please go back to your first slide?
Excuse me, sir.
Yeah.
Sir, there's just a slight correction actually. In her obstetric history, past obstetric history, the first, this one, G1, L1, it was not by LSCS, it was classical caesarean section.
Okay, fine. I'll come to that. That's an important point. He can come to that. Fine. Just go back to the first slide.
Dr. Nimbkar, if we may take a brief respite before you start your interrogation to announce really quickly an opportunity that's available for our SIMSOG members. Would that be okay?
Yeah, sure, absolutely.
Manas, would you like to do the honors?
Hi, thank you everyone. So hello everyone, I'm Manas and I'm from the research team SIMSOG. I'm here to tell you about a quiz event that we are organizing. So this is a breastfeeding awareness research quiz that we are organizing on 23rd August, and it's an online quiz that is from 7:30 to 8 p.m. And early bird registrations are open for it now. It's a great opportunity to learn in gamified way. You will have an opportunity to learn from researchers. So the registration link, I am posting it in the chat. So please sign up for it, and early bird registration are open till first 30 members. See you in the quiz. Thank you.
Thank you, Manas, and thank you everyone for letting us present this opportunity to you. Thank you, Dr. Nimbkar, for graciously allowing us some of your time, and thank you to the presenters as well. That being said, I think we can resume, and we hope to see you all in large numbers.
Thank you so much, Shivani, and thank you so much, Manas. So, coming back to the presentation, Tanaya and
Yes.
Shubhra, in your demographic history, given your first significant point, that's a very nice thing that you have done, that you have quoted all the important demographic details in yellow. Could you tell me what is the significance of each and every demographic detail starting with your age on your case?
Yes, sir. So, sir, in the demography part, the first significant thing is the age of the patient. Here, since the patient is 35 years old, so since with the increasing age, there is beta cell the function declines. So there is increased risk of diabetes mellitus with the increasing age. And sir, also the residence part, if the patient is belonging to rural area, there is difficult follow-up. And if she is belonging to
Or if she is belonging to the urban area, then since there individuals living in urban area, they are more exposed to junk food and sedentary lifestyle. Therefore, there's higher incidence of diabetes in general and gestational diabetes to be seen in urban area population. Occupation. Next is occupation. So she is housewife, which can be considered as a sedentary occupation. And occupation, there's another point that any occupation which includes night duties, since there will be increased sympathetic activity, therefore in those occupations such as even medical students, they are at increased risk of gestational diabetes mellitus.
and also sir educational qualifications, since she studied up till the 5th standard only, she might be not understanding her disease and completely, and she might not understand the importance of compliance to medicines and all. And sir, also since she belongs to lower socioeconomic status, so while prescribing medicines to the patient, for example, if we prescribe insulin, so she might not be having a refrigerator for storing it. So the efficacy of our therapy, all of it decreases. So that is also one point. And then, sir, she is married in a consanguineous marriage. So in her child, the diabetogenic genes will concentrate, and the child is also
Therefore, at increased
risk of having just diabetes mellitus in general. And the parity score, since with increase in parity score, there is increased chances of gestational diabetes mellitus, because the age of the mother would also increase. Plus, she has history of 2 previous LSCS. So the management part also, we have to manage her with LSCS again this time, irrespective of, we cannot try vaginal delivery in her. And also, sir,
last menstrual period, though the date is 22nd December, but she has history of irregular menstrual cycles. So it could direct towards her having polycystic ovarian syndrome, which increases the risk of gestational diabetes mellitus. So, and that's why we can also get wrong dates by Negley's formula. And gestational age currently is 26 weeks and 5 days. It is important for us to differentiate between overt diabetes mellitus and gestational diabetes mellitus. If the female would have presented to us with deranged OGTT or abnormal blood glucose values before 20 weeks of gestation, there is higher risk of her to have overt diabetes mellitus as compared to gestational diabetes mellitus.
Do you still have anything more to answer? That was ridiculously good. Too good. I mean, one of the best demographic details answer that I have seen in my entire examination का brief career. Very good, Tanaya. Very good, Shubhra. You literally didn't leave me any scope to question any single thing in this. Pretty good. Just get on to the next slide. Okay, so the reason for her admission was a deranged OGTT test, and therefore she was admitted for evaluation and optimization. So, do you admit all the patients who get deranged sugar on OGTT? Because, of course, you would agree that India is a region of high ethnicity, a high risk population for diabetes, especially given that your patient has had a BMI of 34 preconceptionally. So, all the more reason for her to have this. But would you admit all the patients with deranged OGTT, or would you just have some threshold or have some criteria for admitting them?
Uh,
Yes, sir. So if OGTT test is deranged and her blood glucose value 2 hours postprandial comes out to be more than 200 milligrams per deciliter. Sorry, sir. If it comes out to be more than 200 milligrams per deciliter, then we need to give her insulin. And for exactly catering the dose of her insulin, we will have to admit such patients. But if the oral glucose tolerance test, the 2 hours postprandial blood glucose levels are between 120 to
199, we might manage her on medical nutritional therapy. So, sir, in that we will advise her to follow the diabetic diet, in which we tell the patient to have 3 major meals and 3 minor meals. And we in each meal it should be, as we had shown in our slides, there should be 50% carbohydrates, 30% of fats, 20% of proteins, fibers, and vegetables and fresh fruits. And sir, this we can try for 2 weeks, and we will ask her again to come, and we will again perform postprandial blood sugar levels.
OGTT.
And yes, and we will see if she has, if the values come come out again to be more than 120, then we have to consider oral hypoglycemic agents,
Or insulin.
or insulin, depending on the test values, sir. So, sir, not every patient is supposed to be admitted. Therefore.
Brilliant answer again. Literally left me with no scope for questioning. What is the source? Which are the books that you have read? Please be honest and just tell me. This is a non-sponsored show, so you can even answer marrow, cerebellum, or whatever. Just tell me the sources from where you have read this.
Some marrow and
Datta.
Oh,
Sharmila Babu.
oh, great. Finally, I heard that from someone. I'm really glad. Thank you. Amazing answers. So the bottom line of everything, Madiha, I believe it is audible to everyone. So deranged sugar, definitely not an indication for admission as they have mentioned. We can have most common reason being uh, your patient not being compliant, or maybe you have given them a chance to be on MNT, medical nutrition therapy, but they have not responded or they have not been compliant with it, and hence you get them admitted. An issue even in Indian scenario is a lot of patients, though they might be compliant, given the socio-economic status that we receive, the socio-economic strata patients that we receive in our OPD setups, they may not have a refrigerator, and hence they are not going to be able to take insulin in the correct way because of course, as you all mentioned, insulin has to be stored in a refrigerator. So even these reasons are pretty much valid in our setup for admitting patients so that they get a proper dosage and proper quality of insulin. And so, apart from the things that you have mentioned though that one of the reasons can be deranged sugar on OGT test. Is there any other test that you can do prior to this test, which is also a little less resource intensive?
Yes, sir. DIPSI test we can do. So in DIPSI test,
What
we
is the
don't
full form
need.
of DIPSI? Could you just start from that?
Full form: Diabetes in Pregnancy Study of India.
Very
So
good.
it is a test, sir, in which fasting blood sugar, fasting state is not required. So it is specially useful for our setup, where patients have to stand in long hours. So, sir, in this we give the patient 75 grams of anhydrous glucose, and we ask the patient to drink that for over 10 minutes, and after sir, after 30 minutes, we see if the patient has vomited. Then we have to, if she has vomited before 30 minutes, then we will have to discard the test and call her on some other day or next day. And if more than 30 minutes have passed, we continue the test, and sir, we check the 2 hours
We check,
postprandial.
sir, 2 hours postprandial levels. If the blood glucose levels is more than or equal to 140 milligrams per deciliter, then we call it to be gestational diabetes mellitus. If the DIPSI test is done on the first antenatal care visit itself, then if postprandial blood glucose is more than 200 milligrams per deciliter, we can call it over diabetes mellitus as well.
Yes.
Okay, correct. So I have a question for you. Given that you have been answering brilliantly, too well, you mentioned about anhydrous glucose. Anhydrous glucose is a very important term here. The reason being, when I did my residency in Sion Hospital, we were getting patients, abnormal number of patients with deranged OGDTs. And we were surprised as to even lean and thin patients were getting their OGDTs deranged. And it seemed like there is some issue with the reagent that they have been using. So we sent in a letter to the biochemistry department to ask them if there is some issue, because whenever we were doing the HGT, basically पिन prick से OPD में जब हम देखते थे तो normal आता था value. तो unnecessary admissions हो रहे थे, patients were unnecessarily receiving metformin. But then it turned out the problem was not with the biochemistry department, but with the blood collection department, with the phlebotomists, because they were not giving anhydrous glucose. Instead, they were giving glucon D. Now, a lot of people were answering for OGTT and your glucose challenge test or DIPSI, whatever. They often say just glucose, 75 grams of glucose or 100 grams of glucose. No, it is not glucose, it is anhydrous glucose. Plus, the glucose that you get in this glucon D and all those glucose powders that you give whenever a patient is or whenever a person is hypoglycemic or tired, to make it palatable, they add sucrose in it. Sucrose, of course, you all know is a mixture of glucose and fructose. So basically, to make it palatable, they add sugar to it, and that significantly increases the glucose content in that. So 75 grams of glucose is said to be approximately 82.5 grams of glucose monohydrate, which is there in those glucon Ds. So to avoid this, you have to ensure that you are giving anhydrous glucose. So now the next question is, what if you don't have what if you don't have anhydrous glucose? What do we do in that scenario? Very honestly, there is not much you can do, because any other substitute is not going to be good enough for this test. So the point to be noted here is anhydrous glucose. Great. There is one thing that you mentioned immediately while answering about the DIPSI test is regarding vomiting. Why would you mention regarding vomiting? What are the reasons that the
Yes.
patient would vomit?
So in first trimester, there is pregnant females have a normally they have nausea and vomiting associated because of raise in the beta HCG levels. Therefore,
So already, sir, they are having that nausea. They are nauseated, and plus this anhydrous glucose. It's not a very good taste. So,
Crazy good answer. Crazy good. Very good answer. Anhydrous glucose literally tastes like आटा जो रहता है, flour जो रहता है, wheat का, it tastes like that. And it has a pathetic taste when you add it to water, which is what triggers vomiting in a lot of females. So absolutely, that is the cause why a female is going to have vomiting. But now that you have been answering so well, I'll just go into a deeper concept, which I'm pretty sure you'll be able to answer. You mentioned that hyperemesis gravidarum is because of HCG. Is it what the recent most guideline says? Is there any other molecule that causes hyperemesis? It's a very high level thinking question, which not even PGs probably would know. So if you do know, that's fine. If you don't, that's absolutely fine as well. But there is a molecule that has been implicated in causing hyperemesis, and it is not beta HCG. From now on, it is something else. Which is it?
Sir, if we would guess, is it
Of course, you can guess. This is something that I wouldn't be getting your marks down for if you don't answer.
LH?
No, LH, no, not really. In fact, during your pregnancy, LH FSH levels are not going to be that high. So the answer is GDF 15, growth differentiating factor 15. So remember that GDF 15 is the molecule that has been implicated. Recent most green top guideline ने ये बताया हुआ है, but that's fine. If you know it, good. If you don't, that's also fine. ठीक है. So you mentioned you spoke about the DIPSI criteria. DIPSI के अंदर जो I है that stands for India. But for all those people who are going to be doing MLE or all those people who are going to be moving abroad, if you are practicing in the US, which is the test that they do for screening?
Yes, sir. So there is two-step testing that is done. In the first step, they give 50 gram of glucose solution, and they test plasma glucose levels after 1 hour. If it is more than or equal to 140 milligrams per deciliter, then they will go for the second step. In second step, they give 100. First of all, they'll take the fasting blood sample. Then they will give 100 grams of glucose solution to be taken by the patient, followed by they will do 1 hour and 1 hour, 2 hours, as well as 3 hours venous blood sampling for glucose levels. If fasting blood glucose level is more than or equal to 95 milligrams per deciliter, 1 hour is more than or equal to 180 milligrams per deciliter, 2 hour is more than or equal to 155 milligrams per deciliter, and 3 hours is more than or equal to 140 milligrams per deciliter. Out of these, any two should be deranged to call it a gestational diabetes mellitus. And these are Carpenter and
Houston.
Question criteria.
Okay. Which is the other criteria? Which are the other two criteria? उसमें से एक obsolete हो गया. Just name them.
Sir, WHO 2030.
That is
No,
the we
no,
are
no, no.
using. There is O'Sullivan criteria, and
Yes,
there is
correct.
NDDG.
National Diabetes Data Group, NDDG criteria. Correct. All of these are theoretical things. It is okay if you don't know them, to be very honest. Your examiner is also now going to be remembering these values. मेरे को याद है क्योंकि मैं ये recently सब पढ़ा हूँ, लेकिन most of your examiners won't remember them. I myself probably wouldn't remember them for a few years. So अगर सिर्फ Carpenter Houston भी याद रखोगे, तो that is good enough. Could you tell me, now you just mentioned about 50 grams का जिसको वो लोग कहते हैं glucose challenge test and 100 gram का what they call it as the OGTT. So the total अगर मैं करूंगा it is 50 and 100 150. In India the total is again the same, DIPSI का 75 and OGTT का भी 75. So the OGTT that you do in India is for 75 grams, whereas the OGTT that you do in the US is of 100 grams. Could you tell me why this difference and what is the basis behind this difference?
So could it be ethnicity, as in Indians are more prone
Very
to?
close, yes, very close. So basically, there has to be some study that substantiates it. Could you possibly dwell into that?
So we are not aware of such study.
Okay, fine, no problem. I'll just give you some time to think about it. Until then, I would want to ask you, could you just mention what are the cutoff values for India ka OGTT once again?
So for fasting values is if it is more than 92 milligrams per deciliter. 1 hour values is 180 milligrams per deciliter, and 2 hours value is 153 milligrams per deciliter, according to the WHO 2013 criteria, sir.
Correct. So I'll tell you the difference. Do you have the answer or should I tell it?
Sorry, sir.
Ethnicity.
Do you know the difference as to why 75 versus 100? Okay, no problem. So now this is an answer that is given in a very few sources. So the answer is that अपन जो Indians है, they are all short-minded people. ऐसा short-term goals अपन पूरा करेगा. आज का देखते हैं, कल का बाद में देख लेंगे. Whereas developed countries have a very long foresight into things that will happen 10 years down the line. And obviously, given how resource constrained are we do tend to think very acutely, abhi current isme kya hoga. Hence, the studies that have been done in India by something that you may know is IADPSG, which is, I think you may know the full form, International Association of Diabetes and Pregnancy Study Groups. इसका जो स्टडी है इंडिया में, दे सेड कि हमारा स्टडी एक हैपो नाम के स्टडी के ऊपर रहेगा, और वो हैपो का जो स्टडी है, हैपो का फुल फॉर्म है हाइपरग्लाइसीमिया एंड एडवर्स प्रेगनेंसी आउटकम्स, या हैपो। उन्होंने बोला है कि ये जो 75 ग्राम वाला टेस्ट इंडिया में कर रहे हैं, उससे सिर्फ इतना पता चलेगा, वील ओनली नो वेदर द मदर और द फीटस और द नियोनेट आगे जाके will they have any complications. So it was a very short term thing that we took into the mind कि सिर्फ pregnancy related complications होंगे या नहीं, वो हमें इस कट ऑफ से पता चलेगा. But the people abroad, they said that we do not want just this pregnancy related outcomes. We also want to know what is the possibility that this female who currently may have GDM will also develop overt diabetes mellitus several years down the line, 10, 20 years down the line. So they had an outlook towards the next 10, 20 years when the female is going to develop overt diabetes mellitus, or basically type 2 diabetes mellitus. And hence, उनके जो values है, they are not outcome based. India के values are outcome based. Outcome मतलब क्या? अगर ये मेरा OGTT 75 ग्राम वाला deranged है, then the outcome may be macrosomia. The outcome may be shoulder dystocia. The outcome may be neonatal hypoglycemia. All these outcomes are based on these values. Whereas उनके जो values है, they are not outcome based, but they tell you that there is a risk of you getting all these complications like metabolic syndrome, heart disease, chronic diabetes, all these things, hyperlipidemia, 10, 20 years down the line. So these are the major differences कि हमने सिर्फ pregnancy पे focus किया है और बाकी वालों ने देखा है बहुत आगे का. So both are correct in their own part. I believe ours is more accurate in our setup, जहाँ पे maternal mortality, morbidity and PNMR, that is perinatal mortality, is pretty high. So it is right on our part to be looking at a very good goal. So ये सब चीज का bottom line है. Remember IADPSG जो ग्रुप ने बनाया है, and HAPO study जिसके ऊपर अपने ये values बनाए गए हैं. That is it. Got it?
Yes, sir.
Yes, sir.
Okay. Now that we have mentioned about Indians being a high risk population, could you tell me what are the risk factors that lead to diabetes mellitus or gestational diabetes mellitus?
Yes, sir. So there are certain risk factors that are associated with previous pregnancy. So if there is a birth of a baby more than 4 kgs in the previous pregnancy,
Previous history of gestational diabetes mellitus.
yes, or if there is an unexplained perinatal loss in the previous pregnancy, then that is a risk factor for gestational diabetes mellitus. And also, sir, if there is family history of diabetes, if there is hypertension, if the female is obese, if she has, as in our case, if she is having PCOS, yes, sir.
So correct, yeah. So you just started off by talking about past obstetric history. So I was just looking at past obstetric part, but okay, you mentioned about the past obstetric part correctly, and then you started off with the present pregnancy or present current pregnancy wale risk factors. Anything else that might lead you into thinking that this female might have diabetes mellitus, or she's at a higher risk of diabetes mellitus? Any specific history? If you elicit it, leading question पूछ के,
Sir,
something that is recurrent.
So recurrent
Vaginal candidiasis.
discharge.
Excellent,
Yeah.
very good. Recurrent UTIs, recurrent vaginal discharge, recurrent bacterial vaginosis, and more than that, vulvovaginal candidiasis. Very classical immune compromised disorders like vulvovaginal candidiasis. So, history of their recurrence even before pregnancy is going to make me think that this female may have an undiagnosed hyperglycemia or impaired glucose tolerance. So, very correctly, as you mentioned, high risk factors. Apart from that, if I have to club the population into high risk and low risk, India का population कौन से risk zone में आता है?
High risk
High
zone.
risk.
High risk. So technically, हाई रिस्क पॉपुलेशन में स्क्रीनिंग सबका होना चाहिए. So if a question is asked, is DIPSI an option? No, DIPSI is a necessity. Screening is a necessity, and not just screening, but even OGTT, the diagnostic test, is a necessity. Now, could you tell me, when do you do DIPSI and when do you do OGTT?
So DIPSI is done in the first antenatal care visit, and OGTT is usually done at 24 to 28 weeks of gestation. But if we are having a doubt whether this pregnant, if like she is having a high risk pregnancy for diabetes, then we can get OGTT done before as well.
And
Very
sir,
good.
if the DIPSI values are deranged, then obviously we do OGTT
Yeah,
to
followed by
confirm.
OGTT.
Yeah, immediately we'll do it. Okay.
Yes.
Uh, OGTT, why 24 to 28 weeks? And is there another window as well?
Sir, 24, sir, as the pregnancy advances, the insulin resistance increases due to various hormones like
Placental hormones,
placental hormones like HPL,
cortisol,
cortisol,
and
and also, sir, that is highest at 24 to 28 weeks. Therefore, we test at that time.
Correct. Is there any other window in the third trimester where the insulin resistance peaks again?
Sir, not sure. Sir, around
करो तुक्का मारो, ट्राई करो.
32 weeks.
हाँ, वेरी गुड. बहुत सारी चीजें 32 36 वीक्स के बीच में होती है. रिमेंबर दैट इज आल्सो द पॉइंट व्हेन योर AFI पीक्स. AFI मैक्सिमम होता है वो टाइम पे. It should make you think AFI वो टाइम पे मैक्सिमम क्यों हो रहा है. Is there a reason for that? It cannot just be that the fetal swallowing is at the least at that point. Absolutely not. Between 30 to 36 weeks, you have insulin resistance that starts peaking again. उसका और जो पीक आता है वो बहुत ज्यादा है, even more than 24 to 28 weeks. And at that point of time, of course, the placental glucose transfer to the fetus increases, leading to glycosuria and a peak in your AFI as well. Which is why वो जो नीट का आंसर है डायलेमा 32 weeks या 34 weeks, it doesn't really make a difference. The point is 30 to 34 weeks के बीच में there is a peak in the AFI, and one of the reasons is going to be your insulin resistance that peaks. So they recommend that you do an OGT also between 32 to 36 weeks, but given that you need to test the patient thrice, 3 बार टोचन देना पड़ता है. All these things make it a little inconvenient for the patient to keep on doing these tests again. So we only do it between 24 to 28 weeks, ideally. Correct. Now that we have spoken all about DIPSI, GDM, and overt diabetes mellitus, is there a new classification that has been proposed by anybody? Twenty 2017.
FIGO 2016 classification is there, which just says hyperglycemia in pregnancy.
sir, it divides hyperglycemia in pregnancy into diabetes prior to conception and
Sorry.
and sir, GDM during pregnancy. So, sir, instead of giving the term overt diabetes mellitus and gestational diabetes mellitus, they have divided it this way: diabetes prior to conception and diabetes during pregnancy. Yes.
The correct terms, could you just tell me what are the accurate terms that they have given? You are slightly off the mark.
Diabetes in pregnancy and gestational diabetes mellitus, and then there's
Very
further,
correct.
and then
Yeah, it
there's
is further divided. Yeah,
into type 1 and type 2.
correct. So a very easy way to remember is diabetes in pregnancy. In this name itself, diabetes is coming first and pregnancy is coming later in the name, the nomenclature. So it indicates that diabetes was there before pregnancy began, and that is what you used to call as your overt diabetes mellitus. And gestational diabetes mellitus, में the gestation part comes first, and then diabetes का word is coming. So it is diabetes that follows your gestation. So it becomes your GDM, जिसको तुम पहले से बोलते थे. And both of these are clubbed under hyperglycemia in pregnancy, which is also why the name of today's session is not diabetes in pregnancy, but hyperglycemia in pregnancy, because that is the correct nomenclature. Remember that. And आगे जाके it has been divided into type 1 and type 2, because obviously your diabetes mellitus cannot obviously and always be because of insulin resistance. It can also be because of some pancreatic disease that the patient might have prior to pregnancy or has had during pregnancy, which is why both these segments, diabetes in pregnancy and gestational diabetes mellitus, have been further divided into type 1 and type 2 each. Correct. So ये था 2016-2017 का PIGO का latest update. Okay. Now in your chief complaints, you have mentioned no complaint of pain in abdomen, leaking or bleeding or decreased fetal count. Decreased fetal count. Decreased fetal movement is a better term. Count मतलब बच्चे का number. That is decreased fetal count. Kick count बोल सकते हैं.
Yes,
Okay.
sir.
Yes, sir. Sorry.
Could you correlate the reason for 26 weeks पे 26 week का patient है तुम्हारा 26 weeks पे pain in abdomen in a patient with gestational diabetes mellitus or any form of diabetes mellitus?
Sir, it could be a complication of diabetes, that is diabetic ketoacidosis, that the patient can present
Correct.
to us.
It
Anything
could be
obstetric?
abruptio placenta, but third trimester more
26
specific.
weeks. No.
Preterm labor, but
Yeah, very good. Correct. Why preterm labor?
so because diabetic mothers, they usually have polyhydramnios, so it can cause.
And also,
Yes.
sir, diabetic mothers are at increased risk of infections like UTI.
Yes,
That might
that is a
cause
bigger reason. Polyhydramnios तो यूट्रस सहन कर लेगा 26 weeks पे कितना ही बड़ा होगा यूट्रस बट इन्फेक्शन कोरियोअम्नियोनाइटिस असेंडिंग इन्फेक्शन फ्रॉम द वजाइना वो नहीं सहन कर पाएगा द मेम्ब्रेन्स आर गोइंग टू रप्चर एट दैट पॉइंट और एटलीस्ट नॉट रप्चर देन पेन इन एब्डोमेन बिकॉज ऑफ द cytokines that are released by those infections, which includes prostaglandins, prostaglandin being a uterine contractant contractile agent that is going to lead to uterine contractions and hence pain in abdomen. So DKA, correct, and the other two causes, obstetric causes, pain in abdomen in diabetic patient. No history of PV leak or bleeding. PV leak, again, PPRM, very common in these patients. Now that we are anyway talking about complications at this point, could you tell me what are the maternal complications of diabetes in pregnancy?
Sir, so maternal complications can be divided into antenatal complications, perinatal and postnatal complications. So antenatal, sir, as we said, the female is at increased risk of infections. Then that could lead to preterm labor, polyhydramnios, and
Diabetic ketoacidosis. If she's on insulin, then she can also have hyperglycemia. Then she can also be more prone to preterm labor, premature rupture of membranes,
and sir, preeclampsia also can happen.
Yes, correct. Why preeclampsia?
Sir, in diabetic mothers, there is placentomegaly because there is fetus hypoxia, so there is placentomegaly as a compensatory mechanism. So,
more in over diabetes, there is
villus
vasculopathy. Vasculopathies are also associated. So the trophoblastic cells will not be able to invade into spiral arteries properly, and there are vasculopathies.
बराबर एकदम करेक्ट बोला वेरी गुड ये हो गया एंटीनेटल व्हाट अबाउट द इंट्रापार्टम और पेरीनेटल कॉम्प्लिकेशंस
sir, since the fetus would be
macrosomia would be there in the fetus. Therefore, there will be increased risk of birth injuries, prolonged labor. There will be increased risk of
operative deliveries, instrumental deliveries, or C-sections rate would be increased. Sir.
And there's increased risk of chorioamnionitis also.
Yes, correct. And postpartum?
Postpartum, so there will be a lactation failure in the mother.
And purpureal sepsis.
And purpureal, yes.
Okay, anything more? I would just want you all to say a little more on purpureal infections, which all? कौन से focus?
So we didn't understand your questions.
What are the various foci of puerperal sepsis that you can have in a diabetic patient? What are the various causes of puerperal sepsis?
So chorioamnionitis can lead to puerperal sepsis.
Chorioamnionitis is going to be an antenatal diagnosis. What about your postnatal diagnosis? The causes?
Catheter associated
UTI.
Correct. Prolonged catheterization leading to UTI, yes. One of the first sources. What else?
So endometritis.
Yes, endometritis, correct. Endometritis is in fact a cause of secondary PPH. Yes, what else? Something very common in diabetics. Surgical site infection. You
Surgery.
cannot forget that. You cannot. Wound gape. Your LSCS का patient है, उसका wound gape हो गया. Surgical site infection. Wound gape is a very obsolete or a very looked down upon word. Surgical site infection is going to be very common in these patients, and purulent discharge from the wound is going to be very common. Apart from that, all your peripheral foci, look at every single place wherever there has been an invasion. What are those invasive sites? You mentioned about a catheter. Think about your peripheral IV
IV.
line जो हमने डाला है. Yes, superficial thrombophlebitis, very common. Apart from that, if a patient has undergone that section under general anesthesia, then you can have a pneumonia that you can have in the patient. Apart from that, if the patient had uncontrolled sugars और उसमें अगर spinal needle जिसमें डाला है, the patient can have meningitis. So all these foci are very important, and in fact, it even previous old infections like tuberculosis can get reactivated in a patient with diabetes mellitus after the time of a delivery, especially if it's been a cesarean section. क्यों? क्योंकि whenever there is any surgical event or any major event in the body, there is stress that is induced, और stress में होता है corticosteroids भी. Corticosteroid से immunity slightly depress होता है, and ये सब reactivate हो जाते हैं, infections reactivate या फिर the body just decompensates slightly. And hence, all these peripheral sites, all these foci of infection show up, leading to puerperal sepsis. And hence, always remember that puerperal sepsis is not all about the uterus, it is about all the sites in the body that can get infected. So, very common in the postnatal period. What about the neonatal or fetal complications? First, the fetal.
So, sir, there will be increased chances of gross congenital anomalies. If the female had overt diabetes mellitus, then there is increased chances of
Chromosomal
abnormalities also.
as well.
Macrosomia can also occur. There can be sudden fetal death also, which can occur. That is basically because of there will be lots of glucose even in the fetal blood. So that will lead to formation of fetal HbF1c. HbF1c.
HbF1c.
So that will decrease the capacity of the fetal hemoglobin to bind to oxygen, and that will cause hypoxia. Hypoxia will cause polycythemia. Polycythemia will cause, there will be increased hyperviscosity of the blood of the fetus. And since there is hypoxia, there will be lactic acidosis also. So hypoxia and lactic acidosis, both of them, that can lead to sudden intrauterine death. Then in neonate, it can cause, since there's polycythemia, there will be lysis of the RBCs when after birth, and that will lead to bilirubin increase in the unconjugated bilirubin. That can cause kernicterus, and that can cause neonatal seizures and neonatal death. There can be respiratory distress syndrome also, because there will be hyperinsulinemia state in the neonate. So this hyperinsulinemia will inhibit the action of cortisol, which is required for surfactant.
For type 2 pneumocytes to produce surfactants.
So respiratory distress syndrome, also hypocalcemia can occur, hypomagnesemia can occur, and
HOCM can also occur due to increase in insulin stimulate causing septal hypertrophy in heart, and it is a reversible complication, sir. And sir, long-term complications in the fetus is that the fetus is at an increased risk of metabolic syndrome, diabetes mellitus,
obesity,
dyslipidemia, and hypertension.
Brilliant answer. Again, I absolutely needn't have even prompted a single thing. Very good. Just one thing that you can do is you can go trimester wise. So in first trimester, you are going to have history of spontaneous abortions and recurrent pregnancy loss. Also aneuploidy. In second trimester, congenital anomalies, as you mentioned. Could you just tell me which all congenital anomalies are most specific and most common?
Yes, sir. So cardiovascular system is most commonly abnormal. In that, most common is ventricular septal defects, and most specific is transposition of great arteries. And in central nervous system, most common is the neural tube defects, and most specific is the caudal
Sacral agenesis
and caudal regression also.
Yes,
and so there could be renal anomalies in the form of renal agenesis,
Polycystic kidney disease.
polycystic kidney,
Huh.
and
Correct. Very good. So congenital anomalies in the second trimester, and in the third trimester, you can have all the complications that you mentioned, like macrosomia. What is the name of the hypothesis that governs the formation of a macrosomic baby?
Pedersen's
Pedersen's
hypothesis.
Yes. Could
hypothesis.
you tell me what is it?
So, sir, there is increased blood glucose in the maternal blood. So, there will be that will lead to hyperglycemia even in the fetus, and this will lead to hyperplasia of the beta islet cells, and therefore there will be hyperinsulinemia in the fetus. This hyperinsulinemia will increase the insulin-like growth factors as well, and that will also insulin inhibits lipolysis. So, there will be increased free fatty acids and fatty acid deposition, especially around the shoulder and buccal region.
So, sir, that
So
will lead to
macros-
macrosomia.
So there will be basically increased growth in the fetus.
Very good. Great answer again. Pretty good. I mean, absolutely no need to say anything. Also, that is same insulin-like growth factor is the one that leads to that HOCM as well. Hypertrophic obstructive cardiomyopathy. Yeah, so IGF-1 is the one responsible. Now, there is a very important point and a very beautiful explanation that you all did. I would like to just repeat it for all the people who are listening. The cause of sudden IUFD in fetuses with mothers having uncontrolled sugars. So there was a very nice pathophysiology that they quickly mentioned. So whenever there is an increased glucose level in the mother, the same glucose, of course, crosses the placenta and goes to the fetus. Now, as we all know, our hemoglobin is known to love everyone except oxygen, be it carbon monoxide, carbon dioxide, or even glucose. So the fetal hemoglobin goes and binds to the glucose and it forms, as they mentioned, HbF1c. HbF1c, yeah. So now what happens is the fetus which requires oxygen to be released, उसमें से ऑक्सीजन तो आ रहा है तो hemoglobin के साथ only glucose. So this leads to a state of hypoxia in the fetus. So to compensate for that, the fetal bone marrow and the fetal liver and the spleen, they say that let me produce more number of RBCs to compensate. So this leads to a state of polycythemia. Now, increasing in polycythemia is going to lead to a very important thing, and that is hyperviscosity. This hyperviscosity means that the blood is much thicker and the heart has to do much more work to push this thicker blood throughout the body. This leads to cardiac failure and fetal demise. Apart from that, because there is hypoxia, your body starts anaerobic respiration and lactic acidosis begins. Lactic acid is very poorly tolerated by the fetus, more so because the fetal liver is not adequate enough to process this lactic acid. And hence, this is another cause for the death of fetuses inside the uterus whenever a mother is having uncontrolled diabetes mellitus. Could you mention a few more things about the neonate? You did mention about neonatal hyperbilirubinemia. Any more neonatal changes that you can mention?
Sir, respiratory distress syndrome I mentioned.
Yes. What else? Apart from the ones that you did mention.
So
Electrolyte.
neonatal electrolytes, so high,
Hypocalcemia.
hypoglycemia.
Hypocalcemia, hypomagnesemia.
Yes, hypocalcemia, hypokalemia. All these things are also going to be very common. Why did you mention hypoglycemia? Any reason?
Sir, so when the fetus is inside the mother, there is maternal hyperglycemia that crosses the placenta and causes fetal hyperglycemia and causes the stimulation of islet cells, causing hyperinsulinemia. So after the birth of the baby and when the umbilical cord is clamped, there is no more hyperglycemia that is coming from the mother, but the fetal hyperinsulinemia is still there. So this leads to hypoglycemia in the baby. So therefore, sir, all the babies of infants of all the infants of diabetic mother should be kept in NICU for blood glucose sugar monitoring to avoid this complications.
Very nice. You also mentioned about kernicterus. Why doesn't kernicterus occur inside the uterus?
Sir, because the increase in the unconjugated bilirubin crosses the blood-brain barrier of the fetus, and already the blood-brain barrier is not very well developed.
So exactly, the baby should already have kernicterus when it comes out. Why does it happen only after birth?
Sir, because placenta maybe take cares of the.
Excellent answer.
Placenta
The
will be.
placenta is the one which is a major conjugation organ inside the uterus. Whereas once the placental support is removed, the baby has nowhere else to go, and hence the unconjugated bilirubin starts accumulating over there. So the placenta is the one that makes the difference and saves the baby from kernicterus. Okay. Um, now, now that we have mentioned about uncontrolled sugars are more commonly seen in what we call as or what was called as overt diabetes mellitus. Is there any way or any diagnostic criteria for overt diabetes mellitus apart from the tests that you have mentioned?
Sir, if the HbA1c levels come out to be
Yes,
more
correct.
than 6.5,
Yes,
then we can direct. So that is directly
yes. The first criteria, there are three criteria. So the first one is HbA1c more than 6.5.
A1C.
What else?
And sir, fasting blood sugar more than
126
126
milligrams per
Correct.
deciliter.
and 2 hours
Postprandial, 2 hours postprandial,
more than 200.
more than or
No,
equal to
it is
200.
RBS.
So
RBS more than 200 is your final criteria. So your three criteria are FBS more than 126, RBS more than 200, or HbA1c more than 6.5. Either one of them, if they are fulfilled, then you can give a diagnosis of overt diabetes mellitus at any gestation or any gestational period. Okay. You have mentioned about no complaints of decreased fetal count. What can be the reason for decreased fetal count in a patient with diabetes mellitus?
sir, fetal hypoxia
Oh
can
yes.
lead decrease in the movement of the fetus. So, sir, the female will perceive it as decrease in the fetal kick
Why?
count.
Could you tell me why?
Sir, if there is hypoxia, though, then sir, there will be conservation of the energy by the fetus. He,
Not really. Something, I'll just give you a hint. Something with regards to fetal brain hypoxia. Which exact system in the brain? That is also what affects your BPP, that is biophysical profile.
so brain is prioritized.
There is one system in your brain that gets affected by hypoxia, which brings changes in your BPP as well as your NST, that is your non-stress test. Which is that system? Correctly answered by people in the chat. The answer is autonomic nervous system. So the thing is, you all have already heard of NST, I would believe. NST
Yes.
or CPT, non-stress test. So the thing is, whenever you are giving any stimulus to the fetal head inside the uterus, that stimulates your autonomic nervous system, and that immediately causes an acceleration in your NST. Apart from that, your normal body ka jo movements hai and all the usual normal autonomic nervous system ka functioning ensures that there is a baseline or beat to beat variability that is persistent. The moment hypoxia is created or hypoxia sets in because of any cause, it can be because of preeclampsia wala, a fetal growth restriction, or in your scenario, diabetes mellitus. In that scenario, this hypoxia is going to affect this autonomic nervous system, because of which you are going to get poor or non-reactive NST. Why? Because the accelerations are going to be lost and your beat to beat variability or beat to beat variation is going to be lost. Why? Because your autonomic nervous system is not functioning enough. So even despite the fetal body or the head has been pushed or you're waiting for it, it is not responding. The same thing is going to be reflected in your biophysical profile as well, wherein one of the parameters is actually body tone and body movement. And hence, this autonomic nervous system, which matures at around 32 to 34 weeks of gestation, these tests like BPP and NST have to be done only after 32 weeks because then only they can clearly reflect your hypoxia. So if your patient is having uncontrolled sugars before 32 weeks, do not do an NST, do not do a BPP because they are going to falsely reassure you or going to be falsely alarming you. Just make sure that you're trying to get the sugar under control and that should work for you. NST, BPP 32 weeks के पहले करना है point. So did you understand how hypoxia is going to affect your autonomic nervous system?
Yes, sir.
Okay. Could you tell me what are the various ways in which you can explain the patient to keep a count of the fetal movement?
So there's Cardiff rule of 10. So
Yes, what is it?
after lunch, dinner, or
Breakfast.
breakfast as well. So we can ask the female to lie down in the left lateral position for 20 minutes, 15 to 20 minutes. And within 15 to 20 minutes, she should feel 10
10
fetal,
fetal movements in 2 hours if she's lying
2
in
hours.
the left lateral position, and if she's performing daily activities, then 10 fetal movements should be perceived in 12 hours. So, sir, this is how we can do antepartum fetal monitoring. One of the ways. Yes.
Correct. So one is Cardiff count of 10. What else? Something that we commonly do in our wards at SIAN.
Um,
So other ways are NST and biophysical profile.
No, what about patient का खुद का perception जो घर पे भी जाके वो कर सकता है? Very common. ऐसा we tell them file के ऊपर दंडी बनाओ. That is literally the words that we use to tell them. What is it called as?
so each time they perceive a movement.
Acha, daily
What is
fetal
it?
kick count.
Yeah, daily fetal kick count. Very good. How do you do it?
So every time they feel so basically they count, and every time they feel a movement, they keep a record in their file.
Yeah, correct. So basically, every time they have a meal, so for the next 1 hour, because of the glucose spike in the mother, the fetus starts moving. And that is when the fetus, when it is moving, you will have maximum movement that will be recorded. So after every meal, that is your breakfast, lunch, and dinner, for the next 1 hour, you have to draw the number of times, lines as to the number of times the baby has moved. And in the entire day, or at least in a period of 12 hours, it has to be more than 10. If not, then the patient has to report to the emergency services department. Okay, so these are the two major ways, count of 10 and DFKC, by which a female can measure the fetal movements. Next slide. So you have mentioned that she has had history of fever and it was undocumented, and she mentioned, so there is no evaluation that was done because she didn't agree for it. What could have been the possible focus? Diabetic patient, but तभी वो GDM थी, but she is not over diabetes, right? But what could have been the focus if she would have been an over diabetic?
Urinary tract infections or bacterial vaginosis.
Yes, very common. Plus, when have you taken this history?
So 26 weeks of and 5 days of gestation.
No, at around what date have you taken this history?
14th August.
14th August. Which city do you live in, or which city is your hospital situated in?
Mumbai.
Mumbai. What is common in this month in Mumbai?
Acute febrile illness. I mean malaria, dengue.
Exactly, tropical illnesses, vector-borne diseases, very common. One of the commonest cause of all these things, of course, she doesn't have fever with chills, but one of the commonest causes for fever during these months, all the monsoon months, are going to be malaria, leptospirosis, and dengue that you have to be checking for. So very common causes of fever. सब लोग UTI बताते हैं, बहुत लोग LRTI, which is also acceptable. Flu, influenza का season तो पूरा 12 ही महीना रहता है अपने पास. A lot of people go till the extent of saying first trimester में chorioamnionitis and all. मत ये सब बात करो, बहुत ही ज्यादा कॉमन है. अपने पास जो पेशेंट आते हैं, they do not have safety nets and all at their home. So they are very much prone to be getting all those vector-borne diseases. So बहुत ही important है that you focus on this. Apart from that, any other common causes of fever in these people of lower socioeconomic cause apart from tuberculosis? Which system? Gastrointestinal causes like typhoid. Very
Type.
common, बहुत बार, yeah, exactly. Poor food habits, all these things that they eat, poorly cooked meals can definitely lead to some gastrointestinal gastroenteritis or even typhoid. So all these causes are possible for your fever if you are getting a patient who is admitted for fever. So do make sure that you're looking at all these causes as well. And do not go and say things like torch, chicken pox and all. बहुत rare है. एंड टॉर्च में तो कुछ होता भी नहीं है, छोटा सा मीजल जैसा रैश कुछ तो आके जाता है, वो भी आया नहीं है, किसी को पता नहीं चलता है, कुछ लोगों को सिर्फ एक दिन का कोराइजा होता है, नथिंग मोर देन दैट. सो नेवर मेंशन थिंग्स लाइक टॉर्च as a cause of fever in pregnancy. Absolutely not. Ridiculous answer that would be. Okay. So she was not compliant for performing any of the antenatal tests. By the way, your patient has a BMI of around 35 and her weight is only 70 kgs. What is her height?
So
4'8" sir.
4 foot 8 inches, very small, very tiny. What is a complication that you will anticipate whenever she is delivering?
So contracted pelvis.
cephalopelvic dysproportion.
Yes, cephalopelvic disproportion. And if it's a stubborn obstetrician who believes only in vaginal trial of labor and he does proceed with that, what will that lead to?
The shoulder dystocia can.
Yeah, correct. So what is shoulder dystocia?
So shoulder dystocia is inability of delivering of the anterior shoulder even after 1 minute of delivery of the head of the fetus.
Okay,
So
so do you start doing all the maneuvers after a minute has elapsed?
yeah, yes sir. Yes sir.
Excellent. Now please do try this in the labor ward, Sion Hospital mein. I hope you get a great experience. 1 minute. Shoulder dystocia mein, 1 minute is criminal. It is like giving the baby a death sentence. Grade 3 HI बैठने वाला है baby को. Let alone grade 3, the baby is going to die. Shoulder dystocia, you may call it a retrospective diagnosis if you're mentioning the 1 minute criteria, but there is no way you can mention this in your exams. Shoulder dystocia is just your shoulders being stuck at the pelvic inlet, and that is it. Nothing more than that. Don't say a minute. A minute is fatal. Minute chodo, even 10-15 seconds are going to be fatal for the fetus. So absolutely not. 1 minute cannot be said. Anyway, so shoulder dystocia hua hai. A very important question, given that you have answered everything very well, which is that important movement in mechanism of labor that is absent in a patient with shoulder dystocia. मैकेनिज्म ऑफ लेबर में वो एंगेजमेंट वो सब जो आता है इंटरनल रोटेशन ये सब which is that movement that doesn't occur.
Internal rotation of, so after delivery of the head, there is a rotation of the fetus such that the shoulder comes in front of, just behind the pubic symphysis.
Are you sure? Because if it was internal rotation, would the head deliver?
So external rotation.
Yeah, answer is external rotation. You may even say restitution if you want, but
Extension.
external rotation is the answer. याद करो, the movement of external rotation is because of the shoulders. So if the shoulders itself are stuck, you will not get external rotation. Whereas internal rotation अगर हुआ ही नहीं, तो वो transfer से anteroposterior baby का head होगा ही नहीं. The fetal head is only not going to be delivered. In that case, you will have non-progress of labor or second stage arrest. Non-progress of labor या फिर deep transverse arrest होगा patient को. तो इंटरनल रोटेशन से फीटस का हेड डिलीवर होता है, whereas restitution is basically the fetal head जो इंटरनल रोटेशन में गया था वो अपनी नॉर्मल पोजीशन में आता है. बट एक्सटर्नल रोटेशन इज द मूवमेंट जिसका हेड का कुछ भी लेना देना नहीं. It is just a movement that is occurring because the shoulders are rotating inside, and because the shoulders are stuck and they cannot rotate is why external rotation is absent in a baby which has had shoulder dystocia. So shoulder dystocia, what are the various maneuvers that you can do?
So, sir, first thing is we call for help. More people can. We call for more people. Second is, sir, we give a liberal episiotomy so that we have more space. So third is that, sir, we
Like Robertson maneuver, wherein we flexion and adduction of the thighs, abduction. Flexion and abduction of the thighs are done against the abdomen. And if that also fails, then we can give suprapubic pressure as well. And
So
if
what is it that you're trying to do? What is the point of this?
so basically, when we are doing Robertson's maneuver, this sacrum gets straightened. So there is increased space, little bit, for
the movement of the head of the for the movement of the
Increase
shoulder.
space. Could you just give me a better space? मतलब कौन सा diameter? Yeah, antero-posterior diameter. So whenever you're doing that maneuver, your sacrum gets pulled posteriorly, your pubic symphysis gets angulated anteriorly. So it is an antero-posterior diameter that increases, which helps you release the shoulders that are stuck in the antero-posterior diameter itself. What is the point of doing suprapubic pressure, and in which direction should the suprapubic pressure be applied?
Sir, suprapubic pressure, sir, to push the shoulder of the.
Is it to push the shoulder downward?
to facilitate rotation of the shoulder.
Correct. Yes, very close. Facilitate the shoulder rotation towards which diameter?
Antero-posterior diameter.
अरे एंटेरो पोस्टीरियर में ही तो अटका है वो.
Oblique diameter.
Oblique diameter. You started off so well. These are very basic mechanism के questions है. Basically, the baby is stuck in the antero-posterior diameter. So what now you have to do? The biggest diameter in your pelvis is your oblique diameter. So you do not push the baby downwards. That is not going to happen because it is a bony obstruction. Bone को कैसा push करोगे? You have to push it in a direction wherein the baby's shoulders become or get settled into the oblique diameter of the maternal pelvis, and then the baby can start coming down. Hence, how do you push it? जब शोल्डर डिस्टोर्शन होता है तब तुम लोग का बेबी का हेड आ चुका है बाहर. सो द साइड वेर योर बेबीज फेस इज देयर is also the side where your baby's chest is going to be there, obviously. So you will push the baby, or you will give the suprapubic pressure in a way that the shoulder is going to be rotated anteriorly. So posterior side से धकेलना है anterior side पे, so that वो oblique direction में घूम जाए anteriorly. So the point here is to make the fetal diameter oblique. And in fact, the maneuvers, all the maneuvers of shoulder dystocia are based on this principle, that you have to make the diameter of the fetus into oblique diameter of the maternal pelvis. So ठीक है, you have mentioned about two maneuvers. What are the other maneuvers?
Sir, rotating the by entering the uterus, we can rotate.
Manual rotation of the shoulders can be done through wood corkscrew maneuver. That is when if we manually rotate both the shoulders, then we call it Wood's corkscrew maneuver. And if we manually rotate only one shoulder, then it is Rubin's maneuver. If this also
rotate
fails,
only one shoulder, are you sure that you're saying बराबर है वो? And what is Rubin's 1 and Rubin's 2?
sorry sir, we are not aware of Rubin's 1 and 2.
Okay, so Rubin's 1 and 2 है. Rubin's 1 में you do the same thing, but you do it from outside the abdomen. You do not insert your fingers inside. So बाहर से तुम लोग बॉडी को पूरा ढकेलने की कोशिश करते हो, so that the baby gets turned into an oblique diameter. But if that doesn't work, then in that scenario, you put your hand inside and you try to rotate the posterior shoulder of the fetus and try to push it थोड़ा सा oblique diameter में. एक ही शोल्डर को तुम लोग हिलाते हो, बट वो जब एक शोल्डर को हिलाते हो वो दूसरा वाला भी डिसएंगेज हो जाता है. दिस इज रूबिन्स 2. Wood's corkscrew में you insert two fingers, your index and your middle finger, of both your hands inside the vagina, and anterior shoulder and posterior shoulder दोनों को तुम ढकेलते हो, and तुम लोग ऐसा एक व्हील जैसा या स्क्रू जैसा घुमाते हो, so that the baby turns into oblique diameter and it comes out. So Rubens जब तुम दोनों हाथ पे कर रहे हो, that is Wood's corkscrew, whereas Rubin's 1 is when you're doing the same thing but you're pushing it from outside the abdomen. So abdomen के ऊपर से ढकेल रहे हो. So these are your Rubin's 1, Rubin's 2, and Wood's corkscrew maneuver. One more thing that you mentioned is posterior shoulder को deliver करना है. Basically, pelvis को decompress करो. Decompress कैसे? Fetal parts जो भी बाहर आ रहे हैं उनको निकालो. So हाथ डालो अंदर. हाथ में से try to grab the elbow. Do not try to do this on the humerus because the humerus will crack. So put your finger around the elbow and swipe it on the anterior side of your body, of the fetal body, and pull it outside. This way, एक हाथ बाहर आएगा तो थोड़ा फीटस जो भी है डीकम्प्रेस हो जाएगा पेल्विस में से एंड वो ऑब्लिक इसमें घूमना बहुत इजी हो जाएगा उसके लिए. ठीक है. All these maneuvers are felt. Is there any other maneuver that is left?
So Gadsden maneuver. In
Yes.
When all the maneuvers fail, we can ask the pregnant female to roll on, and then we can try delivering the shoulder.
Okay, correct. And the last maneuver when everything has failed?
So
Zavanelli.
Zavanelli's maneuver, when we push
Zavanelli's
the
maneuver.
baby inside and then we perform a C-section to deliver the baby.
To deliver the baby. So basically, whenever you're trying to reach this point wherein Zavanelli करना पड़ रहा है, just assume कर लो that the baby is already gone and it is going to be impossible to get a good outcome. बच्चा बच्चा भी, so it is going to land up with a cerebral palsy. Zavanelli is the last thing that you do. A point here to be remembered is these maneuvers are not to be performed एक के बाद दूसरा. They can be performed in any order. The point is the baby has to be delivered within half a minute to a minute. So these are the maneuvers that are going to be useful for getting done with or by trying to get rid of shoulder dystocia. ठीक है. In your scenario, there is nothing. The patient has not done any dual marker. Could you tell me over diabetes में dual marker test पे क्या असर होता है? By the way, before we proceed, the link has been posted in the comment section. So everyone, the feedback link, we have also given the access. Kindly fill the form and I'll be again posting the link. Kindly fill it, the feedback form. We need it for the certificates and also to know your feedback on this session. Okay. So dual marker पे क्या असर पड़ता है over diabetes का?
Yes, sir. So, a dual marker test is basically done to check for aneuploidies, and it comprises of beta HCG levels and PAP-A, that is pregnancy associated plasma protein A levels. So, if there's associated Down syndrome, then beta HCG levels will be raised while PAP-A levels would be decreased.
Correct. What is detecting diagnosing aneuploidy is the only function of dual marker? Is there any other function that they play as well?
Sir, it indicates decreased placental function.
Correct.
Hmm.
So what is the maternal implication? Once a maternal disorders is diagnosed होंगे, your computer is going to reboot in 5 minutes. Please.
Yes. Sir, we have another device connected.
Okay, fine.
So
Okay.
I'll just stop from here. And
Yeah, sure. You can just continue answering from the other one. So yeah, could you tell me which is the other use of dual marker? Maternal use of it.
Sir, just a second.
yes, sir, is the PPT visible?
Yeah, it is clear.
इसमें से audible.
Are we audible?
Not that great.
Hello.
Yeah, you're audible. Yeah,
Hello.
you're audible now.
Sorry, sir. Sir, could you please repeat your question, sir?
Placental dysfunction. So basically, dual marker test also shows placental dysfunction. So if there is uteroplacental insufficiency, I think hypertension.
Sir, yeah, if there is uteroplacental insufficiency, as in case of hypertension, Or
Hypertension is a very poor, vague term. It's a very poor term.
pre-eclampsia. No.
Yeah, preeclampsia. So risk of preeclampsia and fetal growth restriction is also diagnosable on your dual markers. So your PAP-A and beta HCG are going to be low, less than 0.5 MOM, and that is going to be indicative of future risk of preeclampsia and fetal growth restriction. So those are the two things. So of course, given in overt diabetes, the risk of preeclampsia is twice the normal. And hence, your dual marker tests are also going to be useful for that reason, not just aneuploidies, but also to know the risk of preeclampsia and fetal growth restriction. So neither of them were done, so we couldn't know about what was the risk. And apart from that, she has also not taken any folic acid
Folic
supplement.
acid.
So of course, yeah. So new neural tube defects, the risk was anyway high because of diabetes. It has just increased even further. Okay. Next slide. Okay, so these were her values, and they are all very classical of 92 is the fasting has to be fasting. The first 1 hour has to be 180 and 2 hour has to be 155, 153. So she falls in the classical range of gestational diabetes mellitus. No history of polydipsia, polyphagia, correct. Okay. So polyphagia and polydipsia, why have you mentioned that?
So if it would have been overt diabetes mellitus, then there could be polyphagia, polydipsia as well.
So due to increase in the sugar levels in the body of the mother, there is polyuria. So as a compensatory mechanism, there is polydipsia as well. And there are also
Okay.
polyphagia in the mother.
Okay, what about headache, blurring of vision, epigastric pain, decreased urine output, risk of preeclampsia?
Yes,
Yes,
sir.
sir.
Okay, and burning, maturation, fever, vaginal discharge because of the recurrent infections. ठीक है. Past history. Past history, she is a known case of PCOS. Of course, she is morbidly obese almost and very much expected. Now, you have mentioned that your patient has also had already was a known case of hypothyroidism. And what was the dose that she was consuming prior to pregnancy? Did you ask?
150 microgram.
125 it was, then it became 150.
Correct. Very good. So in pregnancy, you either increase the dose of Thyronorm or Eltroxin by 25 microgram, or you double the dose that you give on weekends, that is Saturday and Sunday, because Thyronorm has a very long half-life of 7 days. All levothyroxine supplements have a long half-life. So even weekend पे बढ़ा के पूरा हफ्ते भर वो चल जाता है. So that has been done for her. You have a patient, let us assume that your patient's OGDT values would have been 300, 350. And also she would have had hypothyroidism. What would you have suspected?
Sir, hypothyroidism along with
Raised.
Uncontrolled sugars of 350, 400.
sir, diabetic ketoacidosis.
But
Okay,
hypothyroidism one.
no, not really. The latest classification of ego is going to give you the answer. You would possibly think of type 1 diabetes mellitus. Autoimmune status of that patient will have to be checked. ANA check karo, antimicrosomal antibodies check karo, anti-GAD antibodies check karo. Basically, your female may have antibodies that are not only destroying your thyroid gland, various receptors in the thyroid gland, like thyroglobulin or thyroid TSH receptor, a lot of those molecules, but also you have to remember that it may be destroying your beta cells, your islets in the pancreas. So anti-GAD antibody, which is very classically checked for in type 1 diabetes. So you might be looking at an autoimmune picture. If you have uncontrolled sugar 300, 400, not necessarily will your patient have decay at these levels, but this is what you have to understand and consider that autoimmunity is one of the causes of having both of these simultaneously. In your scenario, though, given that she has a known case, she is a known case of PCOS and also she is very obese, that is the cause of her diabetes currently. Okay, next slide. Menstrual history. Okay, not significant. I already know she has PCOS. That's fine. Next slide. Obstetric history. Okay, you have already mentioned that the first one is a classical cesarean section. Could you tell me why?
So it was an emergency delivery because of fetal distress.
And sir, classical cesarean section, we give a vertical incision, so that is quicker and faster. so we can remove the fetus quickly.
Okay, very rarely done actually. In fact, your fan and steel जो है उतना ही fast, sorry, your जो curve incision होता है उतना ही fast almost your classical incision is there with the added risks of poor hemostasis in classical section. Could you just quickly tell me classical versus lower segment, the difference and which is better?
So lower segment is better because whenever we do classical, next deliveries
Have to be followed by cesarean section. While we can try vaginal delivery in case of lower segment cesarean
there's
sections.
increased
Correct.
risk of
Very
scar
good.
dehiscence also.
Uterine
And
rupture.
uterine rupture whenever we give a classical cesarean section.
Okay, what about the immediate risks? Healing process में?
Healing is also delayed and it takes longer time for
Why?
Sir, because the lower uterine segment is composed of smooth muscles. So
What? तो क्या ऊपर के segment में striated होते हैं क्या?
nahin.
no sir, the lower uterine segment is dilated after the
Dilated. So lower uterine segment dilate होता है?
stressed
Nahin, sir.
this
Sir, the
dilate.
lower uterine segment is formed by the isthmus, which is formed.
So basically, when we make a lower uterine segment incision, the two ends will oppose each other.
Very simple answer here. Your upper segment contains a lot more density of smooth muscle, whereas your lower segment contains lesser density because of the thinning of the lower segment when it is formed from the isthmus. So whenever the healing is going to take place, because your muscles are richly vascular, there is a risk that there might be hematoma or small sinusoids of blood that are formed in the upper segment, whereas none of those risks are present in lower segment. The healing is going to be faster and better in your lower segment scar rather than a classical scar which extends up to your fundus or up to your upper segment. So it is based on your thickness of the layer of myometrium, nothing else. That's it. Okay, so it was a classical section. Very unlikely that fetal distress के लिए किसी ने साइन में KEM hospital. Oh my God, I am offended. ठीक है, अगर उन्होंने किया है तो okay, I am offended and embarrassed, honestly. But fetal distress नहीं होगा, कुछ और reason होगा. ठीक है. So I'll just move ahead from that, assuming I have not read that. Second is a missed abortion occurred at 10 weeks of gestation, following which dilation and curettage was done. Missed abortion, diabetes, could you probably connect them?
Yes, sir. So if there's overt diabetes mellitus, then there can be vasculopathies associated, increased risk of aneuploidies.
Vasculopathies, aneuploidies, a lot of things that can be associated. इसलिए missed abortion हो गया. What is the missed abortion? What is the definition?
So missed abortion is a ultrasound-based diagnosis. So if there is a mean site diameter
More than 25 mm, and sir, if there is no fetal pole visible, then that is one criteria. Second criteria is if crown rump length is more than 7 mm,
millimeters.
and if there is no cardiac activity is seen, then
and third is if cardiac activity was present earlier, but now it is absent.
And
Correct.
it was documented that earlier.
Very good. So missed abortion is very much something that is indicative of some aneuploidy that was diagnosed by the body itself and it decided to abort that pregnancy. ठीक है. The next baby was of 3 kgs, term delivery and previous LSCS. Hence it was delivered 3 kgs, again something that I cannot relate with the microsomia. So all the pregnancies were technically low risk. Next slide. Dietary history, amazing. I'd probably keep it for some community medicine person to take it. Please just get on to the next slide. Next slide. This is very nicely done, but honestly, as an OBGYN now, I don't really think I can give any inputs. Just go ahead. Next slide. Now that you have just shown me the dietary history, could you tell me MNT जो होता है medical nutrition therapy, how long do you have to give? You have already mentioned it. Could you just repeat it? How long do we give it for?
2 weeks.
2 weeks. Okay. And what is the test that you do after 2 weeks?
Postprandial.
OGTT only will repeat.
No, you just do FBS, PLBS, and the values are going to be, what should your values be?
Less than 120,
That is
Fasting
your
should be less
PLBS.
than 95.
90.
Correct. So 95 and 120 should be your values. What if they are more than that? You start the patient on?
Metformin or insulin, depending on.
Correct. So now coming to metformin, is it a safe drug pregnancy mein?
Yes.
Yes, very good. Is there any other OHA that you can give during pregnancy?
Glibenclamide, sir,
Okay, and
and glyburide.
yes, glyburide. So glyburide and metformin very classically are given. What is the advantage of giving metformin? The biggest advantage?
It helps in decreasing weight loss, but that is
Decreasing weight loss, मतलब weight gain करने को.
Decreasing weight.
हाँ, okay. So weight gain कराता नहीं है, weight loss कराता है. But do I want weight loss in pregnancy? How can that be an advantage in pregnancy?
it decreases insulin resistance.
Okay, one of them. Very good. What else? Very important point. सबसे important in fact.
It does not cause hypoglycemia.
Yeah, correct. So it uses your peripheral glucose. And peripheral glucose जब use होता है, it doesn't lead to hypoglycemia. Hypoglycemia नहीं होगा तो fetal demise का risk भी कम होगा. So that is the biggest reason that I'll be using metformin for. So how long do you monitor metformin before thinking of shifting to insulin?
So 2 weeks we again.
Uh,
So
Okay, 2 weeks, correct. And how many times in a day that you have to monitor sugars?
So ideally, we should monitor 7 times.
Very good, correct.
so before breakfast and after breakfast, before lunch, after lunch, before dinner, after dinner, and once at 3 a.m.
अरे नाइस. सो 3 AM के वैल्यू का दो फिनोमेना का नाम बता दो अभी फटाफट.
Dawn
Seven-
phenomenon and
and
Somogi
Somogi's
phenomenon.
Okay, so what are they?
So sir, if after giving the
In dawn phenomenon, so basically the insulin dose that we are giving at the night time, at night time is less. Therefore, at 3 a.m. there will be normal hypoglycemia, but in the morning there will be hyperglycemia that can be seen. But in Somogi phenomenon, the nighttime insulin dose is increased. So at 3 a.m. there will be hypoglycemia that will be seen, and then there will be compensatory mechanisms that will come in by cortisol and human placental lactogen and such enzymes, and that will lead to hyperglycemia in the morning.
How do you treat it?
So, dawn phenomenon, we can treat it by just increasing the insulin dose at night. And for Somogi phenomenon, we'll have to decrease the insulin dose at night.
Very correct, perfectly done. ठीक है. 7 times दिन में गिनोगे? Practical है? Do you practically do it 7 बार?
No.
Very good. So what is a much more convenient way that I'll tell a patient to do it?
She should fasting blood sugar and postprandial blood sugar she can calculate not randomly, but
Okay, so what she can do is आज breakfast के पहले और बाद में, tomorrow lunch के पहले और बाद, परसों dinner के पहले और बाद. ऐसे करेगी तो दिन में से 2 बार ही टोचन देना पड़ेगा. 7 बार नहीं. And that is how she'll maintain. But if she's already on insulin, she will have to strictly do it 6 times. 7 times किया तो अच्छा है नहीं, at least 6 times तो करना ही है. But for the ones who are on insulin, talking about insulin, which insulins should ideally be given in pregnancy?
So for baseline maintenance, we can go for neutral
Intermediate.
protamine hegidon or intermediate acting insulin. And for postprandial hyperglycemia,
we can give short acting
like Lispro, Aspart, or
Lispro and Aspart. Yes, sir.
करेक्ट. तो ये सब जो है वो शॉर्ट है. अल्ट्रा शॉर्ट तो हम लोग देते नहीं यूजुअली. शॉर्ट एंड इंटरमीडिएट एक्टिंग देते हैं. लॉन्ग एक्टिंग देते हैं ग्लार्जिन.
So, as far as we know, there are no studies per se which have been saying that it is safe to give in pregnancy. Therefore, we do not give.
Very good. So until 2-3 years ago, it was said that glargine and detamine are going to cause macrosomia in fetuses. But now a lot of recent studies have shown that they are equally safe as your short acting and intermediate acting. So yes, they can be given. A lot of obstetricians are still not giving it. So it will eventually be accepted and be used in a much more in a much more prolific way. But yes, the answer is correct. A lot of recent studies have agreed to using even long-acting insulins and extra long-acting insulins during pregnancy. Uh, how do you give or how do you calculate the dose?
Basically, if the postprandial blood sugar is more than or equal to 200 milligram per deciliter, then we can start with 8 units of insulin, and then we can cater it according to her blood glucose levels
After the while we are doing the monitoring.
Okay, any better answer? Any way of calculating the dose that you can give throughout the day? ठीक है, before going there, could you tell me intrapartum कैसे देते हो?
So, sir, on the day of induction of labor, the woman does not has to take insulin dose in the morning, and we can give her normal saline, and then we just follow up the blood glucose levels
by glucometer.
Huh.
And sir, if glucose level falls below 70 milligrams per deciliter, we start off with 5% of dextrose solution. And we maintain the blood glucose levels around 100 milligrams per
70 to 110
70 to
milligrams per
100.
deciliter. If the blood glucose level increases to more than 110 milligrams per deciliter, we can give regular insulin, which is given intravenously.
Yes, yes.
Correct. So very correctly mentioned intrapartum wala. So coming back to the earlier question कि antenatally कैसे देना है. So in the first trimester now I'm going to be quoting FOXY guidelines. There are various guidelines. FOXY वाला जो quote कर रहा हूँ. So it says that first trimester में the dose is 0.7 units per kg body weight. Second में it is 0.8. Third में it is 0.9. And at term it is 1 unit per kg. Now ये जो final dose आएगा उसको हम लोग को split करना है. बाय द वे ये मैं मिक्सटार्ड का बात कर रहा हूँ बहुत जगह पे मिक्सटार्ड या एक्ट्रापिड यूज होता है सो इसका कॉम्बिनेशन द मिक्सटार्ड इंसुलिन इज मेड अप ऑफ 70% आइसोफेन और एनपीएच एंड 30% रैपिड एक्टिंग इंसुलिन so in this case that is your aspart so in that scenario because you are going to be eating throughout the day so 2/3 of the dose has to be given in the morning whereas raat ko you'll be sleeping not eating much so 1/3 of the remaining dose of the total calculated dose 1 mg per kg 0.9 mg per kg वो वाले mg sorry units per kg वो जो dose calculate हो रहा है तो उसमें से 2/3 in the morning and 1/3 is to be given at night and that is how you will be calculating your antenatal doses whereas the intrapartum doses you have perfectly mentioned the way you will be giving it so that about insulin insulin की बात कर ही रहे हैं is there any other novel therapy that you know of that you can attempt in pregnancy
So there
can
is
you
a continuous insulin infusion therapy that has come up. So continuous subcutaneous
Insulin
infusion.
correct so very correct you can use that expensive है इसलिए अभी use नहीं होता है but yes definitely you can use it apart from that one of the last questions end organ damage pregnancy में because of diabetes chronic diabetes क्या क्या test करोगे
So diabetic retinopathy we will test for we'll do ophthalmoscopy.
yes
For
Ophthalmoscopy needs to be done every trimester, at least once in every trimester.
correct
We can also do
renal function test for diabetic nephropathy.
yes and a USG kidney as well to look for diabetic kidney
Yes,
yes
sir.
okay
and
what else
2D echo can also be done to check for any cardiac dysfunction.
okay assume कर लो सेक्शन हो रहा है तुम्हारे पेशेंट का LSCS हो रहा है and your patient has to be given general anesthesia डायबिटिक पेशेंट है एक और एक नॉन डायबिटिक पेशेंट है the risk of aspiration is more in which patient and why
Diabetic patient risk will be more.
yes why
So there is
a nerve dysfunction as well.
yes very close you're very
So
close
vagus
कौन सा nerve
so vagus nerve.
yes
So sir
फिर क्या होगा
the neuropathy the reflex the
Gag reflex.
Gag reflex would be weak. In
Not really. Gastroparesis, diabetic gastroparesis. Basically, peristalsis is going to be impaired. And because of that, your gastric emptying is going to be delayed. And again, because of that, तुम लोग का GRD and aspiration, not GRD, aspiration के chances काफी हद तक बढ़ने वाले हैं. So gastroparesis and hence a lot of these patients have to be strictly following वो NBM nil by mouth वाला जो status है prior to the surgery. Okay. Cesarean है, you have two patients, you have only one operation theater, operation table. पहले कौन से patient को लेते हो section के लिए, diabetic या non diabetic?
the diabetic patient is the first patient that we take.
Okay, correct. And what is this sliding scale of insulin that we know of that is given to these post-op patients or post-delivered patients?
Sorry, sir, sliding.
Sliding scale insulin. So sliding scale is basically you have to maintain your sugars between 90 to 120 intrapartum and postpartum period में because that is the risk जो peripartum risk होता है of decay is very high. So you have to ensure that your HGT is strictly between 90 to 120. So you check the HGT too early, and if it goes above 120, then you start the patient on a neutralizing drip, the same drip that you mentioned about 50 units of insulin. Regular insulin is poured in 500 ml of normal saline, and the infusion is kept in a way. There are various parameters. Sliding scale is basically 120 to 140 के लिए एक level होगा, 140 to 180 के लिए एक rate होगा, and more than 180 के लिए एक rate होगा. So it is to ensure that your HGT is maintained in the range of 90 to 120. That is called a sliding scale. Very important. It is to be done for all laboring and post-operative patients. Every single patient, it has to be done. Your sugar monitoring is only and only done by sliding scale का method. तो 120 के ऊपर जाता है तो स्लाइडिंग स्केल तुम लोग को स्टार्ट करना है. स्लाइडिंग इज बेसिकली यू शिफ्ट द इंसुलिन का डोज एज पर द करंट ग्लूकोज और एचजीटी का स्टेटस. तो इन योर पेशेंट राइट नाउ जस्ट गिव मी अ फाइनल लाइन ऑफ मैनेजमेंट जो तुम लोग का रहेगा. फाइनल थिंग क्या करोगे नेक्स्ट?
So since our patient is poorly compliant, we would not really want to try her on medical nutrition therapy for 2 weeks and then come back and then try metformin and all. We would likely admit her and cater a dose of insulin for her. And then we'll do 3 weekly once her TF. Also, we will thyroid dose, levothyroxine. Also, we will increase the dose such that ki TSH is less than 2.5 international units. And following this, every 3 weekly, we would like to do USG to look for macrosomia or intrauterine growth restriction that is occurring or that can occur. And then once after 32 weeks, we would like to do NST and BPP.
Antepartum fetal monitoring.
Antepartum fetal monitoring.
Every week we will do, sir.
And we will ask her to keep daily fetal kick count as well. Or the Cardiff count of 10 when she's at her home. And since her classical cesarean section has been done, so we would like to deliver her around 37 weeks of gestation itself through a lower segment cesarean section. Irrespective
37
of
weeks. Are you sure? 37 weeks. Remember, you mentioned that pulmonary maturation is delayed in the fetuses in diabetics. So 37 weeks, really?
So 38 weeks.
Yes. 38 weeks is going to be ideal for an insulin patient. What about metformin wala patient?
39 weeks.
39 weeks.
39.
And sir, if the patient is on
Diet.
well controlled on diet, then 40 weeks till 40 weeks we can wait.
Correct. So 38 weeks per terminate karoge. Only if there is preeclampsia, then you terminate her at 37 weeks. Concomitant preeclampsia. ठीक है. So with that, you should manage the patient well enough, and also you have to tell her about the risk of her having आगे जाके chronic diabetes mellitus. So she has to be checking her FBS, PLBS after 6 weeks when the insulin resistance has been removed to know whether she was a chronic diabetic. You can even do an OGDT after that point. And with that, our session ends today. Tanya and Shubhra, amazing session. You started on a amazing high. There was a bit of tapering in between, but then again you are ending on a high. That was an impressive session. Great answers and read the topic pretty well. So well done. Everyone else, if you all have any doubts, do let me know in the chat. I'll be online for another minute. There is also a link, feedback link that I've posted. Kindly fill it. We would love knowing your responses. Today's was one of the longest, I think the longest session. Tanya and Shubhra have done a great job persisting throughout, well enough. So do fill the form, and if there is any doubt, do let me know in the chat. If not, we'll end the session and the other doubts can be solved in the group itself. So Tanya and Shubhra, thank you so much. A great session with you.
Thank you,
Thank you,
sir.
sir.
Great. So I believe there are no doubts. So that's it for the session. Good night, everyone. Thank you. Do fill the feedback form. And yes, also, as the research team had mentioned, do fill in the quiz form. The link has already been sent. It will be again sent on the group. Thank you so much. Good night.
We encourage you to ask all your pending doubts on the WhatsApp group of the attendees. It will be beneficial for everyone as well. Thank you everyone for your time.